As one enters middle age, both arthritis and meniscal injury are frequently found to coexist in the same painful knee. It is, however, often difficult to differentiate between the quality of knee pain secondary to a meniscal tear from the knee pain produced by underlying arthritis. Though important in regard to how the knee will be treated, the exact source and extent of knee pain can be quite perplexing. Is the pain a sole reflection of underlying meniscal injury, or rather a consequence of focal or diffuse arthritic change? Indeed, the pain may in fact be due to some complex combination of both. In order to understand this mixed meniscal arthritic condition, it is important to use the words cartilage and meniscus correctly. The meniscus are two washer-shaped rings that cushion the joint and are attached to both sides of the knee. The term cartilage, on the other hand, refers to a smooth, white linoleum-like layer which covers and protects the underlying bone and allows for painless joint motion. Confusion may arise because physicians frequently use the word cartilage to describe the meniscus. For example, when one hears that someone tore his cartilage or had his cartilage removed, what is meant is that person suffered a meniscal tear or underwent a meniscectomy or removal of the torn meniscal fragment. Cartilage injury actually refers to a progressive wearing away or sudden traumatic damage to the cartilage layer. Cartilage injury by definition is arthritis. Since both meniscal tears and arthritis are all too often found together in painful knees, the correct use of the word cartilage and meniscus is important to avoid confusion. Many of us think of arthritic pain as severe, unremitting, almost continual pain. In fact, both arthritis and arthritic pain exists on a long continuum, from mild to severe and from largely episodic to constant. If one were to take the time to discuss knee pain with someone about to undergo knee replacement surgery, they would most likely describe their experience over the preceding decades as marked by periods of pain interspaced with long periods of well-being. The meniscus, to briefly review, are two washer-like cushions found on either side of the knee. A normal meniscus is depicted in this video clip. Note the washer-like structure is stable and no fragments can be pulled into the joint. If we cut the meniscus in half, one would recognize that its shape on cross-section is triangular, taller where it attaches to the surrounding knee capsule, and increasingly pointed as it projects into the knee. Placed under a microscope, the meniscus is innervated only where it attaches to the knee. The majority of the inner portion of the meniscus has no nerve endings and therefore cannot appreciate injury or feel pain. One could stick the proverbial fork into this portion of the meniscal ring and no pain would be appreciated. Pain, as you see, only occurs when pulling or traction is placed on the very peripheral aspect of the meniscus, that portion of the meniscus where nerve endings are found. In other words, only meniscal tears that result in formation of mobile or loose fragments produce knee pain. These torn meniscal fragments become caught in the rotating joint surfaces and pull against their remaining attachment site with their rich nerve plexus. This meniscal flap tear appears like a windshield wiper, which can be seen being manipulated by the probe. To give you a sense of proportion, the tip of the meniscal probe is only 3 millimeters. This tear, commonly called a bucket handle tear, is another example of an extremely mobile meniscal tear, which when displaced into the joint pulls on the remaining attachment points. The last arthroscopic video depicts a large meniscal tear, which would be readily seen on an MRI. However, since there are no mobile fragments, this tear would be asymptomatic, or in other words, painless, and removing it would not be beneficial. These horizontal cleavage tears are commonly found in arthritic knees. In summary, not all meniscal tears are painful. Tears without mobile or loose fragments are commonly found in the presence of knee arthritis and are generally asymptomatic. Unfortunately, MRs tell us only what is in the knee and not what's causing the pain. Differentiating between meniscal pain and arthritic pain is indeed difficult. Both may share the same history and the same physical findings. Moreover, as we have discussed, many meniscal tears are asymptomatic and, to make matters worse, are frequently found in the presence of arthritis. Unfortunately, then, a positive MRI is not conclusive proof that the pain is a result of meniscal injury, rather than secondary to some underlying and sometimes long-standing arthritic change. What is perhaps the most perplexing to middle-aged patients is the fact that injury or sudden onset of pain is not clearly indicative of meniscal injury. Progressive arthritic damage to the cartilage layer leaves the knee more vulnerable to shear and rotational stress. Many individuals first become aware of arthritic knee pain suddenly as a result of previously well-tolerated activity or following injury. At this point, it's certainly fair to ask, what's the clinical importance? And of course, where are we going with all this? Let's continue. You see, whether knee pain is a consequence of meniscal injury or underlying arthritis is indeed important. Arthroscopy is an excellent tool for removing a loose meniscal fragment, with generally expected very good results. However, arthroscopic scraping or cleaning up or debridement of arthritis is inconsistent at best and frequently fails to provide relief. In short, arthroscopy has been shown to be an effective treatment for meniscal tears with loose, mobile fragments, but as recent research has emphasized, arthroscopic surgery offers little permanent improvement for individuals with asymptomatic meniscal tears and whose knee pain is secondary to underlying arthritic degeneration. Standing x-rays can be very helpful in determining the presence of significant arthritic changes. When you stand, the bones of the knee are pressed together, producing a bone-cartilage-bone construct. Since x-rays visualize only bone and not cartilage, the height of the cartilage layer remains invisible. This produces a clear space between the bones of the knee. This clear space, or joint space, directly reflects the height of the underlying cartilage layers. And as the cartilage surfaces wear away and become thinner, the bones on the standing x-ray appears closer together. In other words, the joint space narrows. The degree of narrowing reflects the amount of arthritic damage to the knee. The x-ray on the right reflects moderate arthritis, in this case a loss of 50% of the normal joint height. Severe or end-stage arthritis occurs when the cartilage layers have been entirely worn down, leaving nothing to hold the bones of the joint apart. Not surprisingly, we call this bone-on-bone arthritis. Unfortunately, standing x-rays, although certainly helpful, cannot identify arthritis until degenerative changes become fairly advanced. Areas of exposed bone surrounded by normal articular cartilage is called focal arthritis. Using this understanding of how cartilage loss results in joint space narrowing, it becomes easy to see why meniscal tears are frequently found in arthritic knees. As the joint space narrows, the meniscus becomes progressively crushed, crowded, and shredded. This process of meniscal compression rarely results in the formation of mobile fragments, and the crushed meniscus largely remain asymptomatic and incidental. As a consequence, these meniscal tears which occur with progressive knee arthritis do not require treatment. The focus instead should be directed toward the underlying arthritic problem. Conservative treatment of a mixed meniscal arthritic condition is generally relegated to the treatment of the underlying arthritic condition. Treatment includes anti-inflammatory medication, occasionally a cortisone injection, gentle strengthening, and time. If the patient improves significantly with conservative care, one has further evidence that a mobile and therefore painful meniscal tear is not present. If, on the other hand, pain returns or persists despite appropriate conservative treatment, then one of two possibilities should be considered. The first is the meniscal tear is in fact mobile and painful, and the second is the arthritis is more severe than expected. Arthroscopic surgery may very well be helpful in cases where pain persists despite conservative care, or in situations where a definitive diagnosis is needed. Arthroscopy is performed with a small telescope about the size of a yellow pencil. Micro-instruments which are used to repair or remove meniscal injury are introduced into the knee through two small incisions called portals. The surgery takes on average 10 to 15 minutes and is performed as an outpatient procedure. Arthroscopy, like any other surgery, has its own risk of complications. Infection may occur in 1 in 500 cases. Deep vein blood clots are said to occur once in every 200 cases and associated with the rare risk of pulmonary embolus. A synovial sinus or passage from the knee to the skin may occur, but these are unusual and almost always heal with time. Lastly, complications of anesthesia or any other general complication of surgery must also be considered. Arthroscopy is performed at Hackensack University Medical Center same-day surgery unit under a general or regional anesthesia. Postoperatively, most patients use a cane for 2 to 3 days and begin either a home exercise program or formal physical therapy by the following week. Return to administrative work generally occurs over the next few days, but heavy manual work or athletics will frequently require a period of 4 to 6 weeks to fully recover. If arthritic changes are present, in addition to a painful mobile meniscal tear, recovery may take longer. I hope this presentation has given you insight into the complexity of middle-aged knee problems so that you can understand your particular knee injury and make educated decisions in regard to present and possible future treatment plans. Following this presentation, I would like to meet with you to discuss the different options available for the treatment of your knee. Thank you.